Hi, welcome to the second part of deformity correction with MAXFRAME, in which in this part we're going to talk mainly about deformity planning and phases of the programming. So the objectives will continue the objective that we started in the first part, which is the general root of hexapod programming. And in this part, we're going to talk about the deformity part of the programming and what are the specifics in the MAXFRAME programming. And this will be obvious in the phases of correction, because most other companies do not have these phases, which is in some cases it's a useful adjunct to the program. And always I'm going to give you tips and tricks for easy programming. In the first part, we discussed what is deformity in lots of detail, and we discussed that the deformity has 6 elements: 3 translation, 3 angulation. The translations are in the axial plane, shortening and lengthening; in the coronal plane, medial and lateral; in the sagittal plane, anterior and posterior; and the angulation is still in the 3 planes. In the axial plane, it is internal and external rotation. It is apex anterior or apex posterior, which basically means procurvatum or recurvatum in the sagittal plane, and it's apex medial or apex lateral, which basically means varus or valgus in the coronal plane. And we said that 5 of these can be detected in the X-ray, as we're going to show, and 1 is clinical assessment or a CT scan, but in most of the times clinical assessment, which is the rotation. And also we went into lots of detail about the inputs needed from the software to give you the program. And we said it doesn't make a difference which company are you using. At the end, it falls into 4 categories: what exactly did you use, what is the deformity, and what is the position of the hardware in relation to the patient. I said these are the 3 main things, and 1 small thing, which is the rate of correction, and if there is any locations of concern. And we went into lots of detail in part 1 of the lecture on how to exactly what did you put and what is the relation of what you put to the patient. We're going to speak in lots of detail in this lecture about the deformity, and as I told you, that the number 4, the rate of correction, is basically in most cases you can write the number, and so this is maybe the easiest part after what exactly did you put. The relationship of the hardware to the patient and the deformity is the thing that basically the most important part, and the part that using the X-ray now and perspective frame matching makes it much easier. The objective of this lecture is basically to show the deformity, how do you input the deformity, and how you tell the computer about the deformity, and we're going to go through this in lots of detail. Now let's start talking about the deformity planning. That's the main goal of this lecture. So if you see now, we in the previous lecture we went through the introduction and these 3 first tabs. Now we are in the deformity planning tab. So after you finish this, you're going to go to the deformity planning, which is how are you going to tell the computer and the software about the deformity that this patient has. And once you go into this, you will have the 2 X-rays that you put before that we use for the perspective frame matching, and you will find this on the left side, and we're going to go into details about what is this exactly. So if you see, there is basically 5 parameters that you need to put in both the AP and the lateral: the proximal fragment central line, the PFCL; the distal fragment central line, the DFCL; and then the proximal point or proximal reference point, the distal reference point, which is the PRP and DRP, and then the location of concern. I told you before when we discussed that what are basically the 4 things that you have to put in the computer. I told you the 3 important things, and 1 which is less important, the location of concern, which is this here. You're going to show the software what exactly are you worried about, that you don't want to distract or compress more than or less than a certain amount. And again, I told you most of the cases you do this either you override it, or you will say that this, for example, point, I don't want to increase in length more than 0.5 millimeter. This is like a smoker or a patient with, let's say, diabetes. So this here is not basically part of the deformity. It controls just, this is only for the rate of the deformity. So we will go back, and now we see we have four parameters for items that we need to input in both the AP and the lateral, which is the central line of the proximal, central line of the distal, the proximal preference line, and the distal, the proximal reference point and the distal reference point. Now let's do a live demo of how to put the deformity. So this is the case that we have been using, a varus proximal tibia, and we want to get the correction. So let's now put the deformity in the way that to tell the software. Here, as you said, here we're in the deformity planning tab. We're going to talk about deformity. That's what you're going to use in most cases. I quickly will go through measurement later on, but just now what's common is to use the deformity tab here. And we said there is like four things that you need to put in both the AP and the lateral. And if you remember, I told you everything you can get from the X-ray except the rotation. So you'll put the clinical rotation deformity. So let's say that this patient has external rotation. So you put that, and you say like, okay, this patient has like a 10-degree external rotation deformity. Okay, this is not something that you will get from the X-ray. So don't try to see here how is the deformity. This is say clinical rotation deformity. And we mentioned before that location of concern, that's one of the four main parameters that you tell the computer, but that's not really part of the deformity. So the deformity is in the Sentis program in the MAXFRAME. You want to tell the computer these four items both in the AP and lateral. So you have the proximal fragment central line. So here it is. You click here first, and then you do the proximal fragment central line, which is basically in most cases you can consider perpendicular to the joint. It's 88 degrees, but for simplicity it's here, and you can this will help you in the diaphyseal part, as we're going to see. You can expand it, you can do this, and then you can always move the line, because that's the central line. Okay, so there is two things that you need to tell the computer here: the direction of that line and where it is. So you want to have it in the center, and this will help you. Of course, in case of the proximal tibia, we depend on the tibial spine, so it is in the center or here, and you can widen this or shorten it in the diaphysis to help you. So let's do the distal fragment central line, and in this case here it is. You find here, and now this will help you here. So you move it this way, and then you move this line, you move it this way and here. Okay, so here, so these lines to the side, they're only just to let you know where is the ends of the bone, so you can feel the center more closely. And then again, the location and the angle are important. Okay, so here it is. This is the good angle here, and I would say that this here, so we will that will be our distal fragment line here. And if you see that both these lines, so if you extended this line here, they don't meet here in the osteotomy, which we know because that osteotomy is not done at the deformity. It is done distal to the deformity. But you don't have to extend it. You can extend it, of course, if you want, but you don't have to do that. And now proximal reference point. For those of you who used to use Smith and Nephew, this is what we call the origin and corresponding point. So this is the origin, this is the corresponding point, but they changed the name now to proximal reference point, which you can always use it at the level of the osteotomy. And if you notice when I did this, you see here, the line here gives you the line of where is this on the lateral view, so that you can so that when you come here for the proximal, it's much easier to use it in the same spot, so it does not confuse the computer. Okay, so that line, and when you put that line, it gives you this line here, and this line is very close to the proximal line, so that means that you picked both of them very close to each other. If you want to do it identical, you don't have to do it very identical, but it's better not to have a big huge gap. So here it's on this, and then you see that line became here on that point. So when let's do the same here, distal. So the distal will be blue, and if you see when I put it here, immediately you saw the line here. So you will come here, you click here in the distal, and you put it on that spot. Usually I don't put it in the I put it in the lateral view. I usually go to the center here. So let's go here proximal and use this also in the center, because there is no deformity in the lateral, and we can always push this up here slightly so we can get, okay, so both now they're both in the center here of the bone. So I'm going to talk more about why did I pick this, but this is just in the beginning to tell you here are the 4 points that up and 4 points that are below. Oh, we didn't do the proximal and the distal. So proximal here, the proximal, we know that the center here is usually in this spot here. Okay, so this is the center, and we are in line here. We should be like a 9 degree here, and we know that there is no deformity in the lateral, so we will align them here, and we will do this here. So this here, so we put we have the 4 elements in both views, and when we click on calculate, it will give us the deformity. Now let's go again into more details. So I clicked on clear all here and clear all here, and I cleaned everything. So would like to give more details about basically what does it mean to pick the points for the proximal reference point and the distal reference point. Again, as I told you, when you sync, it will give you both. That's not very important. The difference is very minimal. Let's talk about the proximal and the distal reference point, and what is the difference if you pick them in different level. Some of these information will basically depend on some of the osteotomy rules that I'm going to put it into the next slide, so you understand the basics of it. So here, this is our rings. Here, this is our osteotomy, and if we repeat what we did here, this is the proximal central line. We know here is this is the center here. We can just move it slightly here to be exactly in the center of between the 2 tibial spine. I highly encourage you, I'm going to put it into the comments, to go to the lecture of the deformity correction. There is a lecture that I did for deformity correction. It will give you the basics of how to basically analyze any deformity, and it will talk also about the osteotomy rules that we're going to mention. So here is this the distal central line, and if you can see here, it immediately give you it highlighting this one. So if you go here, you don't have to click on it. It's a minor difference. You don't have to worry about it that much. Here, like this way, you can get it this way slightly. And let's go here. So immediately it clicked both, even if I'm in the lateral. and you can do it here. And the relation, the angle between the two lines, between the proximal and the distal, makes a difference. The position does not make a difference. So if you put it here or here or here, it will not make a difference in the program. What makes a difference is the relation of the points. But this is the central line is to calculate the angle of the deformity. That's why it's important that you understand what is deformity. As we said, deformity are six parameters. These lines will control the two of the angulation in the lateral view, angulation in the AP view, and then the angulation in the axial view. As I told you, it is clinical, internal or external rotation. So we'd like to make them more parallel so there is no deformity in the lateral view. So let's click here in the distal, and then we can make it here, and then here to move it so that's more or less parallel here. You can always override at the end, as I'm going to show you. But now let's go to the important part, the proximal line. So let's say that I pick the proximal at the osteotomy here, which is usually what we do at the fracture. We pick it at the fracture. I'm going to show you an example of a fracture, but this is not a fracture, this is a deformity. So we'll put here, immediately it gives you the line here. So we will pick it here. We will try to raise this slightly up so you're here, it goes into here. And then the distal, if you click the distal here, that gives you the line which is on the same here. So you click it. So try always to use the same to put the line on the dot on this line. Otherwise, it will confuse the software. Now, we talked about the deformity in the beginning. We talked that the deformity is 6 elements. 2 of them are controlled by 2 of the line, and then this will control the clinical will give you the third. Now, these 2 dots are basically going to tell the computer the translation. Okay, so the 3 translation, which is medial, lateral, anterior, posterior, and axial. So basically, let's say that you decided to go. Let's go to the distal, and let's say that you put the distal here. So that's immediately, and then here that tells you that the line should. So your dot should be in the lateral, very close to this line. If it's far away, it will confuse the numbers of the shortening and lengthening. So that's why you have to pick, you have to put it very close. It doesn't have to be like exactly on the line, but very close to the line. And you can see here, what does the computer tells you? It tells the computer that there is shortening and you need to lengthen. So let's say that we, if we click calculate here, sometimes it tells you that there is an issue. That tells you just that there is some that there may be some difference in the AP and the lateral where it's taken from. In most cases, you can just click OK and go. So if you see here the deformity parameters, immediately there is shortening. So that's exactly what we said. Like if you put the distal point proximal to the proximal point, that means that you telling the computer that there is shortening. Let's go back and let me explain that more. So let's see, I have here, so the dots here, let's go proximal, and here proximal, and let's, okay, and then the distal here. So if we bring the distal here, okay, and then you bring here so that they are in the same line here. So you'll see that. So that tells you, so that let's say that we calculate on this, okay, and you click here and you go to the deformity.
you will see that basically there is no translation 1 millimeter. Basically, we just like it's an error in where you put the dot. You can always override it, so like you can do like this and this, or you can keep it. It does not make a big difference. But if you're not planning to do translation, it's better to override it. And then it tells you that there is such angulation 1 degree. Basically, that's basically 0. You can do 0, or you can keep it. In most cases, I will go to 0. Or I will put like 1 degree of posterior angulation, and I'm going to tell you that why I do this. Well, you can do 0 here. And then the bone length, it gives you 1 millimeter only, which basically means that the dot, just you put it not exactly on the line, and the real deformity is basically here. It's the 12-degree verse. So for this, the computer calculated all this. Of course, you're the one who put the clinical deformity, but these are the 6 elements that I keep going back to. 2 of them are by the lines, and 3 of them are by the dots, which is the bone length, the translation, and then 1 deformity. So here it tells you just that this will so that basically will result in the computer telling the computer that you want the distal and the proximal. What is the distal and the proximal? It is the software is trying to bring the distal point to the proximal point. So if I say that the distal point is here, for example, that tells the computer that I want to bring this dot to this dot. Again, it's very similar to the concept of origin and corresponding point in the old TSF, but if you didn't use it, all what you have to understand from the distal point and the proximal point is basically you want to bring this dot here to this dot here. This dot, maybe you put it here, for example, okay? And in this case, it's recommended that you bring the distal here. Okay, so, and let's say that you put it here. That means that the computer wants to bring this point to here. So that means that there is a posterior deformity, posterior translation, there is medial translation, and there is lengthening. So, if the computer wants to bring this dot to this dot, that is the computer that you have medial translation, you have posterior translation, and you have lengthening. So the bone, you want to shorten the bone. Let's calculate. Let's see if that's correct or not. And you click here on the deformity, and you can see what we discussed. Of course, this number did not change the angulation because it's basically with the lines, but the dots change it. 19 millimeter, it used to be 1 or 0. It is that you told the computer that there is medial translation, posterior translation, and it became now too long. And now you take the computer that is long, and please compress, because I would like to get these 2 dots together. So this is the concept of distal proximal reference and proximal distal reference point and proximal reference point. So you're telling the computer, okay, go ahead and bring this dot to this dot, and based on their position, the computer is going to calculate 3 things: shortening versus lengthening, medial versus lateral translation, and anterior versus posterior translation. So I hope now the concept is clear, and what is deformity and how the computer assesses the deformity. Now let's go into more depth, and because this is not just only to describe this point, I want you to understand how to use it. So let's say that you pick this number here, and then you pick this here, and both are there in this here. So you see this will definitely cause an issue here, so you need to bring here, and we can move it between 2 sides because we have the sync. But if we don't have the sync, you'll have to come here and click here which is okay. Just I want you to understand every click here. So you have now, let's say that you tell the computer that this is the point. So then the computer now will look to this two here. Okay, there is no angulation here. There is 12-degree angulation here. There is no, based on these dots here, they're over each other, so there is no translation in either view. So no translation medial, lateral, posterior, anterior, or posterior, anterior, or shortening or lengthening. That's one thing. And there is just 12-degree. So what will happen in this case? The 12, you put the dots here, okay? So these dots will tell the computer the translation. However, by putting the dots here, you're basically telling the computer that the correction will happen at this level here. So what will result is that you will have the bone straight at this level, okay? Which is what you want. You want to correct the deformities. You will have the 12. So you will have basically the line here will come here. The bone will become straight from here. You will get a 12 degree. So you will move this part here 12 degree. This is what will happen if you do this, okay? This is not the best biomechanical, as I'm going to show you in the coming part, but this is what will happen in this case. So let's stop here, and I'm going to show you how is that will look in a diagram. So this slide is from the deformity lecture that I told you. I'm going to leave it in the description, and I really would like you to go and watch it if you haven't watched it. This picture is from Paley and Herzenberg book of the Principle of Deformity Correction, and I'm sorry I flipped the picture horizontally so it coincides with what we did, so you're not trying to flip your brain. So if we picked this point, we in the previous example when we did the deformity, we picked that the proximal reference point and the distal reference point are here and the same. So what happened is we ended, if you do this, you will end with a parallel line. So you got the alignment corrected. So the patient has no more varus. However, there is a shift. The distal part has shifted in relation to the proximal part, and you gain some length here when you put that here, because you put it on the you put this on the concave side, and you put it on the convex side of the deformity, so you were able to straighten the bone but with a shift, and you were able to do it. However, there is some shift. Now let's play with the system again. Let's say that you decided to put the dot here. Okay, let's go to distal here, and we have the sync here, so we can move it easier and faster. We'll move the distal here, and keep the distal here. It does not. We're not doing any correction in this plane, so it does not really make a difference. You can put this here and put this here. Put the proximal here. It does not make a difference. You usually put them in the middle of the bone, but if you're not doing any translation, any correction in the sagittal plane, it will not make a difference. So let's say that you pick this here, and this is here. Let's see what will happen if you do this. So there is no, it's the same thing, no translations in the three planes, but can we do this or not? That's what I'm going to show you in the next diagram. So this is the same diagram that we put before. Again, I'm sorry, I flipped it horizontally so it looks like the deformity and you don't have to flip the picture in your brain. So I flipped it for you. So in the first one, we used the points on the convex part of the deformity, and I told you what happened. We ended into a segment that is in line with the other segment, but there is a translation and there was some increase in the length. Now we use this, basically this scenario. We put the reference proximal point and the proximal reference points and distal reference point in that spot, which is in the concave part of the deformity. So the deformity is like this. We put it in the concave. Can this be allowed? No, because the only way to do this is actually to remove piece of bone. Remember, you're putting an X fix. So you're not doing like an acute osteotomy. So you did not go and take a piece, because if you see here, so basically you did the deformity correction on this point. So the only way to do this is to move this piece of bone this way, basically removing this piece of bone here. And that cannot be done in the X-fix. It can be done in internal fixation, because in internal fixation you open, you remove, and then you put your plate or your nail. But in an X-fix you don't remove anything. You put an osteotomy and you get gradual correction. So you cannot compress to the degree that you remove all this of bone by the X-fix. So it is not possible to do this. It is not optimum to do this, but it is possible. You will gain some length. You'll have a bone regenerate here. You will end with no angulation, but with some translation. However, it is not possible to put the 2 points in that area of the bone as we did in the last example. So what is the solution? So we said if you put it here, you're going to get okay result, but not perfect. If you put it here, it will not work. You will find that the frame is stuck and it doesn't want to. You cannot shorten these because you will be actually hitting bone to bone. What is the best option? The best option is you will go back here to the proximal, make sure that you did it perfect. We'll do it perfect in the center. And then the lateral, the distal part, yeah, I would just maybe move it a few degrees this way. Make sure we're in exactly here, and then here, and then now, okay, this is here, and then here. The proximal one needs to be 89 degrees. And I'm going to show you how to do this. This is what I told you. We're going to go through later on to describe the measurements. So basically, measurements is a way to draw angles. It does not affect the program that the computer is going to give you. So it does not affect the deformity parameter that's going to be exploited from the picture. But it helps you to draw the angle. Let me show you how to draw the angles here. So we did clear all. We remove all the pictures from the deformity. Let's clear all here and go back to measurements. You draw a line. You want to see like the proximal fragment. It's very small. You don't know where is the axis. You can use this. So again, the measurements is just a way to make your to draw some lines if you want. You don't have to use it, and whatever these lines you draw it actually does not reflect on the deformity. The deformity parameters is from the deformity that you put here. This is only purely for your reference. So here we'll use the 4 point. Let's use 4 point here. So for example, I come here and then I go from in between and I look for 88 degrees. Okay, so that's perfect here. So I have an 88 degree medial proximal angle. It usually will get you to 90, and then it goes the 83, so 90 is accepted. I'm in the center. So now I can go to deformity, and this line is here, so I will go proximal femoral and I draw the line here. Maybe I will go 1 degree, for example, here. And now I have the proximal perfect, because I cannot depend on this, because it's a very small fragment. You cannot draw the anatomical or mechanical axis here. So you'll depend on the measurements. And then you go, of course, you can draw this here. And then you go distal. And then you go here, distal. Here it will help us to have the alignment. So we're here in the center and then we extend that extend that line here. Let me just go this way slightly. Okay, go here. Okay, that's very good here. So now so we want to make it that there is no deformity here. So even if you get a deformity, you can always override it, as we said. All right, now let's go to the point that we want to discuss. So we said, okay, let's this is going to give you a line like no angle, but there is translation. If you pick the lines here on the concave side, it's not going to work. So what is the best option? The best option is to do it at the level here of the deformity. And don't stick to the idea of the osteotomy, and I'm going to show you in the next part what is this. This is called osteotomy level rule 2. So you can see here. So we will pick it in that point. Still in the concave side, you cannot do it on the convex side. You cannot do it on the concave side. And that immediately give you the line here. So you can click it here, and then you do the distal, and then you put it on that same spot. And then of course you can put it here. You can basically click any point here. There is no problem, because we're not looking for any correction in the sagittal plane. Of course, if you are doing it, will make a difference, and you will have to pick the line that is exactly where you want. But for you, if it's only coronal, all what you have to make sure that you're picking the line point on this line, so the computer does not get confused on what is the shortening and lengthening. In general, I put it in the middle of the bone usually. So if you go here, I'll put it here, and also I put this here. It's not going to affect anything, so long you're not looking for any deformity correction. And even if there's like 1 millimeter, you can always override it, as we're going to do in the show it to you next. So you can see we did it here on this spot, and that will give you the best result, as I'm going to show you now. So let's go again to the diagram that we have been showing. And again, all this you can see it in the deformity lecture and the principles of deformity assessment and how to do your osteotomies. So basically we have a deformity here. We have a deformity, and we said you cannot put it on the concave side. If you're putting a frame, you have to put it on the convex side, and we have been putting it on the convex side here, and we see how we ended with a straight bone but translation. Now we will put it, despite our osteotomy here, our correction point would be here, as we saw in the last example, where we put the proximal reference point and the distal reference point in this area here. What will happen is you will do translation with the angulation. So you will correct with translation and the angulation, which is here, because we picked this point. So it will give you this area here, this scenario in which you will end with a straight line and correction, and there will be some translation. So here is our patient. You have the varus here. And we put the frame, and we put this point here as the reference, proximal reference and distal reference, and we ended, as you see, with the straight line aligned. There is a translation, as you can see. This is magnification of this part. There is translation. This translation is not a mistake. It's not by chance. It is intended, and it's done so that you can end with the limb straight and aligned proximally and distally. There's some translation here, but it is aligned with the rest of the lower extremity. So I know that we went quickly through this. This lecture is not enough to describe that. You go back to the lecture of the principles of osteotomy, and you will understand that better. But this was important because we're blogging the deformity items into the software, so you need to know which points to pick. So now let's go back. So we pick this line, proximal reference, distal reference. So basically this point will not change because we put them over each other, and all the correction will happen in relation to this line here, which will result into translation and correction of the angulation. Quickly, I told you that when you calculate here, it will give you the numbers. This tells you that there may be some abnormality because of the it didn't correspond exactly to the picture. You don't it's okay. You can just press OK, and then you go to the deformity parameters. It gives you lots of number. You can override any number you want. So we didn't want any translation, so you can go from 1 to 0. We didn't want any translation. Definitely we had the varus valgus, so it gives us 9 degrees. We didn't want any translation. In general, I put like 1 or 2 if I'm doing tibia, I will do apex posterior. Why? Because you have more muscles posterior than anterior. So when you do any correction, especially if you do any lengthening with that, the tight muscle posteriorly will put you into apex anterior deformity. So I correct that with putting maybe 1 degree or 2 degree posterior. If I'm not lengthening, you can just go 0. If in that example, you can just put like 1 degree apex posterior, so that it lengthens the posterior more, and then when you have a tight posterior structure, that makes you in most cases perfectly straight. Now you have all the numbers, you can just play with them. We're not intending for translation, so you 0 them. In tibia, I go 1 or 2 degree posterior, apex posterior, so that when I I lengthen slightly more posteriorly, so I can override that the tight posterior muscle. And then we click save and load. Here is the pins here, or the sticks, showing you the deformity, and you make sure you like it. And then mounting parameter, this is basically the computer calculated all this when you aligned in the perspective frame matching. So that will take care of one of the hardest things that we used to do when we used the old program of the TSF. Now you don't have to worry about it, it's all done for you. So look here, this is it shows you the frame, and you can immediately notice what's going on. So the computer put the osteotomy at the level of the ring, which is not correct. We have the osteotomy here, but because we told the computer that here is the points that we want to correct, and the computer knows that there is here is the proximal and the distal reference, and he knows that we have the angulation. If you see, there will be an overlap here, and if you look from here, it is at the level of the ring. Why? Let me just keep going here. So we go to the phrases. This is where it comes to the point of structure of concern. As I told you, this is part. We can stop here. I'd like to talk about the structure of concern. Usually, in most cases, I would click here and I would say, okay, let's do this in 30 days, for example, or 20 days. You can do that. If you want to be more scientific, or if there is something that you're really worried about, so let's say that we put this. Let's go back here to the deformity planning, for example, and we would say that the location of interest is here. Why? It's usually use it in the concave part of the deformity, because that's what we're going to lengthen. And here there's no it's basically you put it in the middle because there is no correction. Here there's the concave part because that's what we're going to lengthen. Sometimes if it's let's say that this is a valgus deformity and you're too much worried about the nerve, you will put the nerve or the point, for example, here. You will move it from here to here, and you will say that and then you will leave it here so the computer does not get confused. And you will say that you don't want this to lengthen more than 0.5 millimeter. You don't want to stretch the nerve more than this. So this is an arbitrary place that you will pick. Usually, as I told you, in most cases, you will pick the concave side. and you will put 0.5 millimeter or 1 millimeter, whatever you want. Now let's calculate, and it tells you that you change, and then it tells you that there is some discrepancy that happens frequently. You can just press OK, and then you go to deformity parameters. The deformity didn't change because the structure of concern has nothing to do with the deformity. We're going to do the same thing here. We don't want any. We will go for 1 degree apex posterior prophylactic. We don't want any translation here. And then in translation, they will say, okay, there is 9 degrees. So we end here. You refresh, okay, and then save. It will show you the deformity. There's some various deformity. If you look here, this is medial and this is lateral. There is various deformity. If you flip, this is if you look at from posterior. Here is medial, here is lateral. So there is 9 degree. We didn't put any translation, otherwise the sticks will have moved. And then the as we said, the mounting, it's calculated for you, and as you see, it has put the osteotomy at the level of the ring. Why is that? Because we actually told the computer that the proximal reference point and the distal reference point are at the level of the ring. So the ring is put here and we put it here. It will, because we did that, we didn't put these points at the level of osteotomy. If we have put it at the level of the osteotomy, we would have seen the ring here. And we can always play with it and show you the difference. Like, let's go here back, deformity planning. Let's say that we here clear all. We're going to do it very quick, and then we're going to here draw this line, and then draw another line here very quickly, and then proximal here and distal here, and have the distal here, and then the proximal, put it here. I'm just going to show you if how it will work, and then the reference, put it here, or we can move it here into the concave, and then calculate. It will tell you there may be some discrepancy, and then we go to the deformity parameters. If we see just like 0, 0, and then no translation here, and then save and update. If you look here to the frame, you will see that the frame is at a higher level than the osteotomy. So if we go this way here, the frame, let me just turn it correctly, because okay, so you will see here that now the osteotomy does not look at the level of the ring, because we moved the numbers down. So this picture here, we can always change it to sticks. It is not at the level of the ring because we change it the points, and the computer will change the osteotomy based on that. Now we go to something, the last part of this. I'm going to go to show you another example for a fracture, and I'm going to show you more scenarios if you change these points. But let's go now to the phases. This thing here is an amazing thing that the Synthes MAXFRAME has it. Most of the other companies don't have it. It allows you to create phases. Like, let's have an example of, for example, some sort of a non-union with shortening and deformity. So you want first to compress a little bit, so you make a phase to end with compression, and another phase to start the correction of the deformity. Or let's say that you want first to lengthen, and then after you lengthen, you start the deformity correction. You can also create phases. This is the idea of the phases in general. I'm not going to go into too much detail on how to make it, because in most cases you will just go regularly, and you will just come in for the correction. You'll do it in one phase. However, just know that the MAXFRAME has the ability to create phase. You can always create a new phase and make a phase for compression or a phase for distraction, and then for the deformity correction, and you use the zero deformity or copy from the initial deformity. What does this mean? Like this here, for example, I made the phase exactly end as we started. So what's the difference? We can just say that I'm going to end, for example, 5 millimeters short. Okay, so what does this mean? So it means that at the end of this phase, everything will be the same except it's going to be short. So because this is, let's do it again. So copy from the initial deformity. So this is how we started, so, and this is how we will end. So there is no change, but I'm going to do one change. For example, I'm going to ask the computer to lengthen for 5 millimeters. So that means I'm going to make it 5 millimeters long, or 5 millimeters short if I'd like to compress. And then you create another phase after that. So you create a save and update. We'll go through the days later on, but let's, for example, say this override, and then you do this over 5 days, and then you save an update, and then now you create another phase that you will end with zero deformity. So everything will become zero. Again, in most cases you will not do this. In most cases you really don't need to create phases, but this is something that nice that the MAXFRAME has it. You can the easy thing, as I told you, you go for the phase here, and then let's do this in 5 days also, or 10 days, and then now save and update. And then now you have two phases. The phase one will end exactly as you started with 5 millimeter compression, and then after that the phase two will end with everything at zero. Let's remove that, and then here you have only one phase at the end, zero deformity. Okay, so this is only one phase. You ended, of course, at a zero deformity, and then you do this over maybe 10 days. If you want to another option, if you're worried about the area of concern, let's say that you want just to lengthen 0.5 millimeter, and save an update, and it will give you is less than 0.5. Yeah, so it tells you you're going very slow, and then after that you will say you can put a phase name, one phase correction, for example here, and then save an update, and then you look for the treatment plan, always, and then adjust here. This is the start day, adjust the plan, and you always need to look into the frame, make sure you like it, make sure that this is the correct frame you applied. Again, this is the different scenario that we put, but you want to move here and make sure that you like it. So here's the initial, and then you go correct till it goes straight. All this again, you need to make sure that looks as the correction, that looks like a left side. You may do the whole program wrong, put it as right instead of left. So you need to look to the picture, make sure that that's what you have in mind. Let's do again here, come here, and in the deformity we change it. Let's change that, clear here, clear all. Clear all, and clear all here also. And let's go back to where we are and sync, so we can do it quickly. And here, here, and the point we'll put here, and then we'll put it here, and then here, the area of concern is here, and then the same thing here, and then we get this one with no deformity here, and then proximal reference. Oh, so you put it on the, so you see, you put it on the same line so the computer is not confused, and then here in the middle here, no problem, and calculate. Okay, so now it has the deformity. Here we put it back, we put the points back where we can get the best result. And then you can go here for the deformity, you look and make sure you like it, and then here is the frame mounting that happened, but as we applied the perspective frame matching, and if you see here, the frame is exactly at the level of the osteotomy because we moved the points down, so the computer thinks that the osteotomy, I'm sorry, we moved the points up, so the computer thinks that now the ring is at the level of the osteotomy. What happened is we just changed the points, but we didn't change the point of the osteotomy, but the computer now thinks because we picked the point at the level of the ring, that the ring points and the osteotomy are all on the same side. Phases, as we said, in most of the time you don't have to use different phases, just one phase correction that will end with 0. So if deformity at the end is everything 0, that's the default. You don't have to carry any other phases. It's one phase, give you everything, and then you can either put the location of concern lengthen changes 0.5, or you can override and just, I'd like to get that, for example, in 10 days, and then you save and update. And you will end like this. You get to the treatment plan, you get, this is my treatment day, and you go here and you move it, and you see the changes here, and you can see it here. The computer, because we put that the point is here, already the computer put that this areas here are overlapping. They're not overlapping. But that's what the computer will do to make sure that you're correcting from the concave side, and it will end exactly here on the same edge. What will happen in real life is that there will be a length gain in this area because you did not start with overlapping bone, you started with bone at the same edge, so you will end with an increase in the size. Let me show you a few things that, like for example, to understand more, let's say that we move this here. Let's go here, phases, I want to show, and then you generate the plan. Once you approve the plan, that's it, you cannot change anything. But let's see here, the numbers, it starts at the last day will be 183, and then here is 161. Let's say that we came here and we changed this position here for this all the way to here. I just want to make you to understand that concept, that that's not going to change anything in the plan. It may change in the picture here, so you calculate. So we moved it all the way outside, like calculate, and then we'll go to the deformity. Deformity, here we used 9 and 0 and 0 and 1 apex posterior. So we save and calculate. So we see when you put the mounting here, you will find how the computer looked to the model now completely different because you put the line here. However, when you go to so here one first phase which will end in 0, and let's see the treatment plan, and you look to the treatment and you just, here's the day, and then you look here, it ended exactly the same as the other one. There is no change, so the correction is not really affected with where did you put the line. It's where with the what is the angle of that line. The picture changed, but the deformity plan did not change. One thing that I'd like to mention here, it's very important. before, when we had the old programs for the TSF, adding shortening or lengthening was very complicated. We used to put grids and see how are we going to extend 2 points together, the origin and corresponding, which is now the proximal and distal. With the new program, especially with the Synthes one, it's extremely easy. You have two options. First, you can come after you do the deformity planning, you come to this. I told you can always play with these numbers. If you find something that you don't want, you can override it, and you can always play with. If you want to lengthen, you will put that it's short, or if you want to lengthen, you can put it's long. Another very simple way, extremely easy way, is in the phases. So you can just have the first phase and end with 0, and then you can come with the second phase here. And if you want to lengthen, you can just you want at the end of this phase to the bone to be 10 millimeter long. Or if you want to compress, you can at the end of this phase, you can I'd like to make it short. Or you can put this phase in the beginning. If you want to compress, you will put that you want it first short, and then you end this phase with 0 deformity. But if you want to add the lengthening, which sometimes happen, you have like a deformity with the shortening, get some lengthening, get some deformity correction, and then if you want to add length now without being worried that you have to worry where is the lengthening axis will be, you just end with the deformity 0 deformity, and then you add phase 2, and in the phase 2 you tell the computer I want the patient to be 5, 6, 7, 10 millimeter long. So the lengthening becomes much easier now. Lengthening with a deformity, it used to be extremely hard to do. There is like correction point and corresponding point, all this before methods. Where do we put these points so that we can get the correction? You don't have to worry about that at all. My recommendation is just get the deformity correction and then add phase 2 in which you want to add the lengthening. After we talk about deformity, I'd like to now give an example of a fracture cases. The good news is it's much easier than deformity. You just use the proximal femoral point and the distal femoral point on both sides of the fracture on corresponding points, and you align the lines of the central line in the proximal and the distal fragment, and you should get your correction. So let's go quickly through a case. This is one of my patients. At that time, he was 13-year-old, polytrauma patient. This is an open fracture, 3A left tibia fracture, ipsilateral. He has a femur fracture. We took him urgently to the OR. So we took this patient urgently to the OR. Actually, there were two patients on the scooter, two adolescents, both got open tibia. This one got femur and open tibia, so we took him urgently. We put a lateral entry nail, and we put an X-fix, got a preliminary reduction. I put a MAXFRAME on, and by the time we finished, it was, I think, like 6 or 7 a.m. We started to work from 11 on these two cases. I was so exhausted, so I didn't do what I told you to do in the first lecture. I told you always get the X-ray in the OR by yourself. Make sure you have. So these are the X-rays that they got in the recovery after I left. I was so exhausted. And of course, maybe you can use this one. You have here the 12. I know now you're expert. You know how to put the points to do the frame matching. Of course, the lateral, the tech did a good job. So he got the lateral of the tibia. Not very good lateral, but at least there is some lateral of the tibia. But we are interested to see the frame so that we can do the program. And I really regretted this. It took 4 trials. And of course, the patient is in pain, so it's not easy to get the X-ray. And I had to have one of the residents be there to make sure that we get the frame, and we were able to do the program. So always try to get the X-ray in the OR while the patient is asleep, and you can look at them and make sure that you can see the frame and you can put the program. So now we do the program. I remove the patient name. We went through this in lots of detail in the first lecture. and then you come here, and we use the X-ray, the good ones. If you see the good X-rays, they are good X-ray for the frame. They're not good AP and lateral. That's not a big deal. The computer and the software will detect, and it tells you that there is a 96 degree basically difference. They're not like 100% 90 degree to each other, orthogonal. And there is some rotation. This is not like a perfect AP, but still you can get the program. Deformity planning, that's why we're here. It's extremely easy, not as we talked in deformity. There's you just for the proximal fragment, and you will put it in the proximal, and you'll use the 5 lines in the distal here in AP and lateral, and you need to do it perfect in both of them. And then the choice of the proximal reference and the distal reference is very easy. You choose the proximal reference in the point here, and in the proximal fragment, and the distal you choose the point that should come to it. So here is the this is the fracture here. This end here should come here, as if you're doing like open reduction, and you put this point here, the same thing here. Here is this X-ray, the distal fragment here, the proximal fragment here. You would like to bring them together, so you decide on the point, you decide on the central line, and you put the rotation clinically, and basically so it will give you the numbers, whatever numbers give you. I would not change it, because that's basically what the computer calculated, so I will not override or change anything. And then the computer will give you the mounting parameters. You don't have to do anything in that. And then the phases, always in the acute trauma, it's usually one phase. It's and then you can always do what I'm going to show you later on, but you just end with phase that will make the deformity 0. And I usually override it. I put here 4 days, but I just get the program, and I do it. If the patient is comfortable, you can do it acutely. Usually it's not that tough, or you can do it through 1 or 2 days. But if the patient still in the hospital, you can just do acute correction, look to the last line, and do it. And then you get the treatment plan, and you check to make sure that everything looks fine to you. So now we're going. This is the last thing we're going to talk about. Is in most cases, whether it's fracture or deformity, you do the program, and then you run it, and then you take an X-ray at the end, and it looks great, but it's not perfect, or you want to get some more compression, for example, in a fracture. So it is very easy through the program in the MAXFRAME. You will whatever day you need, like in the last day or the day before the last. And then you will click here on replan. Once you click here, it will take these numbers and start working with them, and then you upload the new pictures, and click on it, and then it will go much faster and much easier. I do this in most of my cases. Most of the cases, some cases you will do it and you run the program, and then the patient will go exactly as the plan says. But most of the cases there will be some either overcorrection, undercorrection. That happens all the time. You just go to the day that you are in, and you click on the replan, and then it will take these numbers here as the starts and start generating a new program. So now the computer will call it the second run. You can obviously change that to put the whatever name you have, and you have 2 options. In most cases, I'll tell you the truth, in the second time I will not use the perspective. I'll use the standard, and when I go to the deform, so if I click here the standard, and then if you started here, I will say, for example, in most cases, if it's like, for example, a fracture, I'll say that the patient is, for example, 3 millimeter too long. And if I notice that there is some varus, I'll put okay, like there is 2 degree varus or valgus, whatever I found. And then I will save an update. In this case, you don't have to put you don't have to put again the X-ray for the deformity. Here the computer used the last numbers that you had before. So we clicked on the last day for replan, so it will generate these numbers here, and it will take you to the same mounting parameters. I like this for my second, for the, I call it the fine-tune programs, because usually you know what you have, like, okay, it looks great, I just want to get it 1 degree varus, I want to fix that, or there is like 1 degree or 2 degree apex anterior that usually happen, let me fix that. So you don't have to plot the deformity, you can just tell it to the computer. In this case, you just click on the standard and then you come here and you put what you want. Few degree translation, you say, oh, it looked like everything went great, but there is some translation, you put like 5 degree lateral, and for example, no, nothing here. So you can play with that. And then that, why is that helpful? Because you don't have to upload another X-ray and do the perspective frame matching if it's only a few degrees or few millimeters, that you know which direction. So it usually can get you what you want. If you don't want that and you want to upload the program again, X-ray again, and get a perspective, you just get here and then you will be prompted to go through the steps. This one you don't have to repeat it because it will still generate from the line that you clicked on replan. By this, we have concluded the lecture. I'm sorry it was a long lecture, but it is important. There's lots of details and basics that you need to know in order for you to put the program. Most of the things that are in the 2 lectures are actually the basics, and you will use them whatever frame you're using. There are very few things that are specific for the MAXFRAME, but I hope this lecture will help you whatever program and whatever device you're using, because most of the things are applicable to other frames and other software.